Hello, good evening, friends. We are meeting after a long time, long gap. I was busy with so many other commitments. That's why I could not take these lectures, but I'm so happy that I could restart the lecture series. And I thought this is a very, very important topic, which is very useful for the postgraduates as well as for the practicing obstetricians. That's why I chose to restart my lecture series, what I call 2022 2.0 in the stylish way. So this is called Next Generation Partograph. I was just other day browsing through my lectures in the YouTube, and I found that my lecture on partogram has the maximum views. But today I'm going to delete that lecture. The reason is that is old already. In fact, this new labor care guide came in 2020, but it did not somehow become very popular, maybe because of Corona, and not many people spoke about it. I gave my first talk on this labor care guide in Hyderabad Foxy FIGO conference, and none other than Sir Arul Kumaran highly appreciated it. He has contributed a lot to this labor care guide. And he said, Murli, you have simplified it and it is very useful for all of us, and hope that people will take it up. So I thought it's a very important topic for the postgraduates because this is almost like new, though it is 2 year old. And even for practicing obstetricians, lots of thoughts have gone into this. Some of them may be controversial. Some of them I may not agree totally, but on the whole, it's going to be very useful. So let's go with this now. WHO Labor Care Guide 2020 Users Manual. My entire lecture is based on that, but I have tried to simplify it as much as possible. And it's aptly called Next Generation Partograph. What is WHO Labor Care Guide? According to them, it's a tool like Partogram. To be precise, it's a A4 size paper that aims to support good quality, evidence-based, respectful care. It's very important to understand that during labor and childbirth, obviously, irrespective of the setting or level of healthcare. What does it mean? This tool can be used in primary healthcare, secondary and tertiary healthcare centers, as well as from Africa to America, third world countries to the first world countries. So that is the meaning of irrespective of the setting or level of healthcare. For a positive childbirth experience, this word is so beautiful. It's going to repeat many, many times in this lecture, positive childbirth experience. So obviously, it's called the Next Generation Partograph. The recommendations, there have been 26 new recommendations in this, in addition to the 30 existing recommendations, from labor through to immediate postnatal period. If you remember or recall, the old partogram stopped at first stage of labor. There was nothing for the second stage and definitely nothing for the third stage. But this one is throughout the labor, also into immediate postnatal period. That's one more thing you have to understand. What are the guiding principles of this? Labor and childbirth should be individualized. We always say in medicine that every treatment should be individualized, but especially in obstetrics, and we know in so many years, even the postgraduates, even with 1 or 2 years of experience, you realize that each woman has a different take in the labor. It's different for each woman. And that's why it has to be individualized, and it should be woman-centered, not obstetrician-centered. No intervention should be implemented without a clear medical indication. This is very, very important. We all know this, but we somehow don't follow this. There has to be a clear medical indication to do any intervention, whether it is inducing labor, starting from that, or whether to do an artificial rupture of membranes, or whether to use an instrument, or whether to do cesarean section. Whatever it is, there has to be a clear medical indication. Only intervention that serve an immediate purpose and proven to be beneficial should be promoted. Just because you want to do something, you should not do. Only those interventions that are serving the immediate purpose as well as proven beneficial by evidence-based medicine should be promoted. So in other words, a clear objective that a positive childbirth experience. That's what I told you. I'm going to repeat it many times. It's already second time it is coming. Positive childbirth experience for the woman, the newborn, and her family. So it's a total package. It's not just the woman. Should be at the forefront of labor and childbirth care at all times. This is the guiding principle. So what are the aims of this LCG? I'm going to call it labor care grade or LCG. Guide the monitoring. We cannot simply monitor the way we like, but it is guiding us. And documentation. It guides the documentation as well of the well-being of women and babies and the progress of labor, all the three. The progress of labor, of course, that's how we know about the well-being of the baby as well as the mother. So it helps us in monitoring as well as documentation. It guides health personnel to offer supportive care throughout labor. So this is something which most of us now tend to forget. The woman requires support throughout the labor. We cannot say just we know it, we have also delivered many, or I myself have delivered. We cannot say like that. The woman actually, it is almost like I remember my mother telling that it's like going through another janma or another birth for herself. While giving birth to the child, she goes through another birth. It's almost like going to another world and coming back. So she requires support to ensure a positive childbirth experience. This is a third time, positive childbirth experience for women, to prevent unnecessary use of interventions in labors. The same thing is being told in different ways. Doesn't matter. The ultimate aim is that we must remember that we must give a positive childbirth experience to the woman without using unnecessary interventions, and that also supports auditing and quality improvement of labor management. So labor care guide aims at all the four. Plus, it assists health personnel to promptly identify and address emerging labor complications. So it's not just you support, but you have to identify and also address in time the emerging labor complications by providing reference thresholds. This is the most important thing of the labor care guide. That's why I'm underlining it. Reference thresholds for labor observations. So it is very beautifully given. I'm going very slowly because it doesn't matter. It has to be understood very clearly. And once you understand this, it just becomes so easy for you and you will be able to handle it, answer it, and master it. That are intended to trigger reflection and specific action or actions if an abnormal observation is identified. So that is the aim of labor care guide. It's for whom? Already it's been told in one way, it's going to be told in another way. For women and their babies during labor and birth, regardless of their risk status. Once we told regardless of the setting, that is third world country or the first world country, and the level, that is primary, secondary, and tertiary care. Now I'm talking about regardless of their risk status, whether they're low risk women or high risk women, in both you can use this labor care guide. However, the LCG was primarily designed to be used for the care of apparently healthy pregnant women and their babies, that is women with low risk pregnancies. Of course, having said that, it doesn't mean that you cannot use it in high risk pregnancies. You can use it in high risk pregnancies also, and you can beautifully use it to identify the complications earliest, because in high risk pregnancy, the labor complications are much more than the low risk pregnancies. The high risk women may require additional and specialized monitoring and care. That's okay. That is in addition to labor care guide, but labor care guide is basic. It's the bottom line, whether you are high risk or low risk pregnant woman. Guiding principles, of course, to summarize what I said so far, is emotional support from a companion of choice, effective communication by staff, pain relief strategies, regular labor monitoring, documentation of events, audit and feedback, oral fluids and food intake, mobility in labor and birth positions of choice, pre-established referral plan, and continuity of care, and finally, respectful, positive labor and childbirth care or experience. So I'm going to encircle this: respectful labor and childbirth care. That's the total aim of labor care guide. Now, having given such a long prelude, or what do you call the introduction to this, let me now come to the business. When to initiate labor care guide? Here comes the major difference between the old WHO Partograph and the new labor care guide. When woman enters the active phase of first stage, of course, that's same for old Partograph also. But what is the difference? The difference is, when will you say that she has entered active phase? Both old Partograph and this new labor care guide are started when she enters active phase of first stage of labor, regardless of her parity, whether she's primigravida or multigravida. So what are the things I'm telling? Labor care guide can be used in third world country or first world country, primary care or tertiary care, low risk or high risk. Now I'm using one more thing: regardless of parity, primi or multi, and the membrane status. And here comes the major difference. It is equal to or more than 5 centimeters. It inadvertently came 4 because the old WHO Partograph started at 4 centimeters. So you have to now change your mindset, change your tongue. There can't be slip of tongue, as I just now had. It is 5 centimeters, almost halfway through the so-called 10 centimeter dilatation that we always say in a first stage of labor. So the active phase is actually not from 4 centimeters, it is from 5 centimeters. Then what do you call that before 5 centimeters is the question. I hope this slide, I have made that 5 so big that it just gets imprinted in your mind. Okay, so I'm going to underline again that regardless of parity, whether she's primigravida or multigravida, it is 5 centimeters is the starting point of labor care guide. Now let me explain what do you call what happens before 5 centimeters. Probably it's called latent phase. Latent phase has always been there, but it was not very clearly defined earlier. Now they are trying to make it little more clear. It's a period of time characterized by painful uterine contractions, not Braxton's contractions. Braxton's contractions are not that painful and they are highly regular. These are also not regular, but they are painful uterine contractions and variable changes of the cervix, including some degree of effacement and slower progression of dilatation up to 5 centimeters for first as well as subsequent labors. So there is no difference between primi and multigravida as far as latent phase is concerned. As far as active phase is concerned, it is that period up to 5 centimeters where the cervical dilatation happens, but very slowly, very erratically, at a different pace in different women. And there is pain, but it is not a regular contraction. That is latent phase. That is indefinite. It can run sometimes hours, sometimes couple of days also. That is exactly why they are saying don't start Partograph in the past, and now they are saying don't start labor care guide until she is 5 centimeters dilated. I hope I'm clear. Now, what is active phase? I've already told you this. The period of time characterized by same painful contractions, but one extra word comes here, that is regular painful uterine contractions. Regular is the word. Okay, so a substantial degree of cervical effacement. There it was some degree of effacement. Here it is called substantial degree of cervical effacement. All of you know what is effacement. It is just the taking up of the cervix. Dilatation is opening up of the cervix, like that. So if cervix is this long, effacement is this, and dilatation is this opening. And more rapid, there it was slower, cervical dilatation from 5 centimeters until full dilatation for first and subsequent labors. So I like their wordings, first and subsequent labors, which means primary and multi. So duration of first stage of labor. This is a very, very important concept, because I myself have grilled from 1990s till even the beginning of this year, I should say, when I was teaching Partograph, that, you know, the first stage is this many hours, and this is how the cervix dilates, and all those things, based on Philpott's Partograph, which had alert line and action line. It's now time to say goodbye to alert line and action line. Women should be informed that a standard duration of the latent first stage has not yet been established and can vary widely from one woman to another. That's what I said. It can be few hours to couple of days. This has to be clearly mentioned. Otherwise, the lady, their relatives, everybody will pressurize you to do off a cesarean section just because she has got some painful contractions. She gets tired so fast. Unless we are convinced, we are aware of this. This is all evidence-based. This is not nothing from anybody's pocket. So only then can we convince the lady that you are only in latent phase and it is variable and you must have patience and don't make me lose my patience. However, the duration of active first stage from 5 centimeters until full cervical dilatation usually does not extend beyond 12 hours. So it's the same 12 hours we used to teach, but now what we are telling is slightly different. The 12 hours after 5 centimeters, not the total first stage. So usually it does not extend beyond 12 hours after 5 centimeters and 10 hours in the subsequent. There is a difference in the duration. So in primary gravida, it is 12 hours after 5 centimeters maximum. And in multigravida, it is 10 hours after 5 centimeters. That is also the maximum. So 12 hours in primary and 10 hours in multi. The progress with spontaneous onset, because here you are not giving heavy uterotonics. Cervical dilatation rate of 1 centimeter per hour during active first stage, as depicted as alert line in old Partograph, is unrealistically fast for some women. That's what I said. Of course, Philpott and others, they did a long study, years together they observed, but they somehow gave us a pattern which said usually cervix dilates after 4 centimeters, 1 centimeter per hour, and that's the alert line. But now we realize that it is too fast for some women, at least, if not for all. It is inaccurate to identify women at risk of adverse birth outcomes. hence not recommended for this purpose, nor for identification of normal labor progression. So based on that 1 centimeter per hour in primary, we drew an alert line, and when it crossed, we said it is to be alerted and some action has to be taken, or we said maybe there is some tardiness. We divided the labor into cervical dilatation arrest or low profile cervical dilatation, all sorts of things we said. So all those things are gone now. Labor may not naturally accelerate until a cervical dilatation of 5 centimeters that I just now told. Therefore, interventions to accelerate labor and birth, such as oxytocin augmentation or cesarean section, before this threshold is not recommended. As I said, you have to convince the lady, provided that fetal and maternal conditions are reassuring. This is like a disclaimer. Both maternal and fetal conditions should be all right. The cervical dilatation rate slower than 1 centimeter per hour after 5 centimeter alone should not be routine indication for obstetric intervention, which is again telling in a different way that after 5 centimeters, don't force the lady or yourself to have the cervical dilation 1 centimeter per hour. It can be 1 centimeter per hour in some, but it can be more than that. But how long you will wait? You can wait up to 12 hours. But again, in that, there are different things which I'm going to tell shortly. The progress of second stage. This is something new in labor care guide. The old Partograph didn't have second stage. Here we are having second stage. In first labors, birth is usually completed within 3 hours. Of course, the 3 hours, I'm not very comfortable talking because I always believed that it should be 2 hours maximum in primary gravida and 1 hour in multigravida. But I remember very well one of our seniors went to UK and there they were waiting for 3 hours, 4 hours sometimes. But now anyway, WHO is saying maximum 3 hours you can wait in primary gravida. But again, the disclaimer is that provided there is no fetal distress, there is no maternal distress, there is no incoordinate uterine contractions, there is no signs of any obstructed labor. All these things go without telling. If everything is normal, only then can you wait for 3 hours. I want to tell it again and again. In subsequent labors, that is in multi, birth is usually completed within 2 hours. Again, we all know that it should be 1 hour. So 3 hours and 2 hours, these are the maximum limits. Again, let me put the disclaimer, provided everything is fine. Everything is fine means baby is fine, mother is fine, obstetrician is fine, and uterus is fine. When not to initiate, of course, this is putting in another way, LCG should not be initiated during latent phase. Telling same thing again and again to impress upon probably all of us. However, it is expected that women and their babies are monitored and that they receive labor care and support during the latent phase also. You may not start plotting on the labor care guide, but you should not say, okay, I'll come after 2 days, or I'll come after 1 day, or I'll come in the evening. Somebody should be giving her support and she should be monitored for, of course, if it is high-risk patient, then you have to monitor closely for whatever high-risk factor is there. Even in low-risk patients, you have to monitor her time to time. But maybe the frequency is lesser. Once initiated, labor care guide will support continuous monitoring throughout the first and second stage. So once she is 5 centimeters, it is a close monitoring, continuous monitoring, both in first and second stage. So, and second stage, I'm underlining that, or I'm circling that. So because the old Partograph didn't have second stage monitoring. Where should LC be used? Again, telling it in a different way, LCG is designed for use at all levels of care in health facilities, although the plan of action will vary depending upon the level of care. Suppose it is primary care center, the plan of action is shifting. Sometimes secondary care also is shifting. Whereas in tertiary care, If there is some problem, you may use forceps, you may use cesarean section, or you may just augment the labor or whatever is required. That's the meaning of this plan of action will vary. The use of LCG can facilitate early identification of potential complications. Hence, it should contribute to timely referrals when required. Suppose you are using it in a primary and secondary, it can be used to make early decisions for timely referrals. So now I come to the all important, I'm going to sort of unveil this WHO LCG. It looks exactly almost like a old Partograph from a distance, but then I will give you closer views subsequently. So just have a look at it. So by and large, it looks like the same thing, same A4 size paper with so many squares, so many columns, so many rows, and so many sections. Yes, LCG has 7 sections adopted from the previous Partograph. There are slight variations, of course. First section is obviously identifying information and labor characteristics at admission. Second one is, this is probably the new one, supportive care. The third one is, of course, care of the baby, fetal monitoring. Fourth one is care of the woman. Basically, it consists of cervical dilatation and descent of the head. Labor progress, again, it means the same thing. Medications, even last Partograph had this, but now we can make it more clear. And 7 is shared decision making. This is again a new thing in the labor care guide. So these sections contain a list of labor observations. So what are these observations? I'm going to teach you shortly. So let us have a closer look at this labor care guide. So here in this particular slide, you are looking at section 1 to 4. Don't worry, I'm going to elaborate each one of them part by part. I'm going to zoom in each section and each column, each row. And section 5 to 7 are seen in this particular slide. Today, I will take as much as possible. Probably I will not be able to continue all the 7 sections today, and I should not rush through this part. So today I will take as much, and if I can't complete, obviously I will continue tomorrow. Section 1 probably is the easiest one, where it is only identifying information and labor characteristics at admission. So what do they have? So let me zoom in now. It has got name of the patient, parity, primigravida or multigravida. We call it gravida index or gravidity index. Labor onset, when was the labor started? It includes maybe latent phase, but you have to know when actually it started. Active labor diagnosis. When did you do the active labor diagnosis? When was it 5 centimeters? Or at the time of admission, how many centimeters she was? She need not be always 5 centimeters admission. She may be 6 centimeters. She may be 7 centimeters. Doesn't matter. But if she's 6 centimeters or 5 centimeters and above, you know that she's already in active stage of labor. But you need to know when it was started. Ruptured membranes. This is very, very important in old and new Partograph. When did the membranes rupture? Because usually after the membranes rupture, I remember the standard teaching has been in Manipal that you should not wait unduly for more than 12 to maybe 14 hours, because it will ask for infection, it will ask for maybe dry labor sort of a thing, and you will all be in trouble. And the next thing is risk factors, if any, whether she's diabetic, whether she's preeclampsia, whether she has got any other risk factors. So it has to. So it's a basic information and probably the simplest one. So this section should be completed with the information obtained when active labor 5 centimeter diagnosis is confirmed. So you can write down initial part, but it should be completed with the information obtained when the active labor, that is 5 centimeters, she comes. Okay. So here is an example. This is straight away from the WHO labor care grade. Mary Jane Williams is the name they have chosen, and we are going to follow Mary James only, Jane only. So here she's gravida 2. They call it parity, but we call it in India gravida. She's gravida 2. Labor onset was spontaneous. Maybe you could have written the time there when it was. But here they are saying active labor diagnosis, the date only they have mentioned. You could actually mention the time also. And ruptured membranes or not? Yes, it was ruptured at 5. That is 5 a.m. we would take it as. Risk factor, history of stillbirth in the past maybe, and anemia. So this is how you can complete the section 1. Let's go to other sections, but I'll give you a general idea what is coming up in section 2 to section 7, how to fill that up. This contains list of labor observations, different observations we are going to make in section 2 to section 7, and should be recorded for all sections soon after the woman is admitted to labor room. That means once she's admitted, depending upon whether she's 5 centimeters or not, we have to start entering into these sections. The remainder of the LCG is then completed following subsequent assessment throughout the labor. Monitoring to action. To ensure the systematic and consistent application of the LCG, health providers are encouraged to use the following approach. What is that? Assess first, record, check, and plan. So this is the systematic approach they have to observe. Assess, record it, document it, check again, and then plan accordingly the complications that arise. So this is very, very, very important to understand. I really took some time to understand this when I first read the labor care guide. So I felt it is very important. So I am dedicating 2 slides or 3 slides to make this very clear. So there is something called time axis and alert axis. Now, what are these things? So as you can see at the top, for all observations, there is a horizontal time axis, this one, for documentation of corresponding time of observation. So I'm highlighting it in a blue box. So this is the timeline. As you can see here, in this row, you can write the actual time. And here, the lower one tells you that it is at the end of 1 hour, 2 hour, 3 hour, 4 hour, 5 hours, 6 hours, 7 hours, like that, up to 12 hours. That's what they said. After 5 centimeters, you cannot go beyond 12 hours. If she crosses 12 hours and still in the first stage, means there is something wrong. That's why they have only 12 hours they have given. Are you clear about it? And you can already peep into the second stage there, and it is only 3 hours. The second one is a column. Vertical alert. This is the one, the alert, which actually gives the reference values for determination of any deviation from normal observation. So you have a timeline for every observation, and you have what is the alert or what is a reference value for that particular observation. So that is given in the vertical column. And then we have second stage section to continue the observations made during first stage, except for cervical dilatation, because you know that at the end of first stage, cervical dilatation is over, full dilatation. But things happen thereafter also. Head keeps on descending, head has rotation, this and that, and so many other things will happen. So that is observed for the next 3 hours. It is in the green box. So you have a blue box, which is horizontal timeline. You have a red box, which tells you about the alerts. That's why I've color coded them also. And you have a green when the baby is going to come out. It has got the green signal and it's going to come out. So 12 hours, 3 hours, and these are the alerts. So let us look at this, how to record that. As I said, in the upper row, you write the actual time. 6:30 is the time, probably she was 5 centimeters, and it is at the end of 1 hour. 7:30, 2 hours, and this is 8:30 beginning, and 9:30, 10:30, 11:30, like that. And she has reached second stage by 12:45. She has reached quite fast. So that is how you write the time. So first row is time, registered the actual time of observation, and second row is the hours, identifies the number of hours that have elapsed during the course of the labor. All right. So I now go to the second section. Having understood what is timeline, what is alert line, let us make it slightly faster now. As far as the second section, first section is identification, second section is supportive care. So here there are different observations to be made. Number one observation is companionship, whether there is any companion, whether there is husband, whether there is mother, mother-in-law, whoever it is. If it is yes, you write Y. If it is no, you write no, N. And woman has declined any companion, you write D. So what is the alert here? If you write N, no companions, means it's an alert. The second observation is pain relief. Yes means Y, N means no, D means woman declines to receive pharmacological or non-pharmacological pain relief. Some people feel that I have to go through the pain, then only I'll be satisfied as a mother. I don't know, maybe. So here again, if you write N means it's a alert. Third observation is oral fluids, whether she has taken oral fluids or not. If she has taken, you write Y. If she has not taken, you write N. If she has declined, you write D. But if you see N in your column, that means it's to be alerted. So here, alert is at every level, not just the alert line.